Welcome back. This is section 4 of the breastfeeding education. This will be our final section. We're just going to kind of wrap up, go through a few parent question and answers and a few case scenarios. Before we do, there are a couple things I wanted to point out that I didn't discuss before. You may have some families who ask you, we get a lot of requests for nipple shields. Maybe someone used a nipple shield with their previous pregnancy, or they have a friend who used a nipple shield. So I just wanted to show you what those look like. These are two different versions of a nipple shield. It's basically an artificial nipple that mom would wear over her breast to create the artificial nipple at the breast. Here in the birth center, we don't often use these. The reason being colostrum is so minimal and so thick, it has a hard time passing through these small openings here. You will see these used more often in the NICU environment where babies start out on an alternate version of feeding and they're using these to transition back to the breast. Indications for these could be a flat or an inverted nipple if the baby's challenged to get a hold of mom's breast, or nipple trauma. If the mom's been so traumatized at the nipple, sometimes this can create a barrier to help her tolerate the latch a little better. The two different versions, this is a full nipple shield, this is a cutout. This is cut out so that baby's upper lip and nose can have skin-to-skin contact with mom. So depending on her positioning, she would place that on her body, wherever baby's nose was going to come in touch with her. They do come in different sizes. We size them to baby's mouth, not to mom's nipple. And again, we stock these in the lactation office. On occasion on our floor, if we have a readmitted mom whose milk supply has been established, we may find a reason to use these, but they are not commonly used in the birth center setting. So if you get a request for one of these, feel free to refer them to lactation. We can get involved and discuss further. But that's what they look like. Those are nipple shields as opposed to breast shells. So you have breast shells and nipple shields, two different things. The breast shells are available in every clean room, and you do have access to these. Again, the small opening would be for that flat or inverted nipple from edema. She would use this very, very briefly before she attempts a latch. The other opening here is a larger ring. That would be for nipple pain. So this is nice and soft. She can wear this against her body long-term without causing any additional pain. And again, the idea is she puts a bra on, puts the nipple in the center there, and it just creates a little dome of airspace so that nothing's rubbing on the nipple. So if she's really, really chapped, really, really tender, she can put some lanolin or breast milk on the nipple and then wear the shield or the shell, excuse me, in her bra, and that'll give her some protection. So again, breast shells, nipple shields, two different things. If you're confused, just get lactation involved. We can help. The other thing I wanted to mention in terms of pumping, the flanges come in different sizes, and these are sized to mom's nipple. So you can see maybe in those two different openings there, this one would be like a 28.5. This is like a 30.5 millimeter size. Our standard is a 24 millimeter size. So if you're working with a parent who has an exceptionally large nipple, you may have to up the sizing to fit her more comfortably. When it's fitting properly, just the nipple should pass back and forth. Excuse me, it should not rub. If it's filling the chamber and rubbing on the edges, it's going to be too painful. She can apply lanolin or nipple balm before she pumps to be more comfortable. But if it's filling this whole area and rubbing, she needs to go up. At the same time, if she goes so big and the whole areola is pulling into the chamber, it's too big, and it needs to be just right. It should be a nice snug fit, just the nipple passing without rubbing on each edge. If you have to up the size, this is available in the clean room. It comes in a box like this. Just know that this is the next size up. It's not just a loose cap covering the piece. It has to go in here. You connect the rest of the device here, and then the breast pump suction will keep that in place. But this is a size itself, so you should start there, and then if that's still too tight, then you would move larger. So I just wanted you to see those two things there. So get back to section 4. Again, this is just a reiteration of what the role of a lactation consultant would be here on our unit. We are the clinical experts in lactation management. We develop policies and education materials. We teach classes and write care plans, and we're here to promote breastfeeding success for our patients. As nurses, the expectation is that you will have, especially as a postpartum nurse, when you're working with the breastfeeding population so closely, you should have developed effective skills for, giving consistent messaging with these guidelines and policies, and just supporting basic breastfeeding, positioning, assessing for a good latch, getting moms pumping. So this presentation was designed to help you build confidence there. Lactation consultants are here to extend that support. We'll give more comprehensive education, especially to first-time moms. We'll go in and do a really thorough education session, and we'll help anybody overcome any breastfeeding challenges by helping them establish a plan. But the expectation is for you as nurses, regardless of your role on the unit, every one of you, again, with an initiation rate of 92% or better, most of these parents plan to breastfeed. So making sure you have a good general understanding of breastfeeding and how to support these families is really critical to your role as a nurse in this environment. So when would the patient be seen by lactation? We print a census of every baby on the unit every morning, and we go through every feeding record. If we see that there's been some issue with the feedings, we'll mark them for a visit. We have a whole list of babies that we will automatically see. We'll see the late preterm babies, the SGA babies, multiples, any mom who has a history of breastfeeding surgery or breast surgery. But for you, there are some things that'll come up that we won't know about. So if through conversation you realize she had a history of a low milk supply, or she has nipple damage that we're not aware of, maybe she's a first-time breastfeeding parent. She's not a first-time parent, but a first-time breastfeeding parent. Please notify us of those things, and we're happy to see those families. We do tend to wait at least 12 hours before we see families, and that's intentional. We know that everyone is sleepy after the delivery. We know that babies commonly are disinterested in breastfeeding. So we want to try to time our visit at a time when the babies are more active and likely to latch, and also when parents are a little bit rested and more able to retain the education we provide. So it's not that we can't see them before 12 hours. It's just we try to wait the 12 hours to make sure the visit is most beneficial to the family. There are additional resources. If you're not already aware, the Get Well Network is set up in every patient room on our unit, and there are breastfeeding videos already preloaded in there. So if they, in the lower tile, if they click into the breastfeeding support tile, there's a video library in there, and they can look up videos on latching and positioning, that hand expression technique. The hunger cues video is out there. So if you're feeling at all insecure about your ability to support breastfeeding, know that that library is there, and there's some excellent videos out there, and encourage your families to watch them. They don't even have to watch them in full. They can kind of, watch what pertains to them. You can order additional videos through the Get Well Network, but we've tried to already preload what's critical to our population. There's also the Patient Education Clearinghouse. Again, to get there through the grease board, you go to the top rung where it says UMHS links, you drop down, click on Patient Education Clearinghouse, and there you can search breastfeeding, and you'll get our entire library of handouts. Again, for night shift, if you're here when maybe there's not a lactation consultant available, know that some of our feeding plans are out there translated in other languages, so they can be really helpful when you're working with some of those families. These two resources, the Get Well Network and the Patient Education Clearinghouse, I've told you about the breastfeeding resources out there, but they're also full of other forms of diabetes education, Foley care, things like that. So just know that both those resources are excellent if you aren't already aware for general patient education. As far as personal use breast pumps for home, through the Affordable Care Act, most insurance companies have started covering double electric breast pumps almost at 100%. I think most companies it's 100% coverage. So know that that's an insurance benefit. It's not something the hospital provides for these patients. It's not, we don't have a durable medical equipment company on site to give them a pump while they're here, but we are able to put in an order for the pump. So if they arrive and they don't have a double electric breast pump in their possession, we can enter the order. The order is signed off by one of our attendings, and we send that over to CareLink. That's the durable medical equipment company that we work with. CareLink will contact them at home and arrange for delivery of the pump to their home. But again, it is an insurance benefit. So if they don't qualify for a pump, or if they're not able to get a pump, it's something they should take up with their insurance company and determine how to go about that, because it's not a hospital benefit or something that we provide here. Our role is to enter the order if they need an order entered. For all those things, I just wanted you to see, I'll switch screens here. This is their admission folder they get when they check in. And in here, there's a really helpful, it's on this left-hand side all the way to the back. There's a handout that talks through the process for getting a breast pump. So you can refer them to this, and it has CareLink's phone number. So if they don't receive their pump, they can contact CareLink directly. And then there's also just a breastfeeding handout. This is about 15 pages long, but it covers just about everything we've talked about in this presentation. It covers supplemental volumes PACE bottle feedings, milk storage guidelines, all of our outpatient resources, our general helpline. So know that this is in there and it's an excellent resource for them once they get home. For discharge teaching, again, that's the admission folder with the 2 handouts that you can refer them to. We do have outpatient clinic support. We have access to see their schedule. So if we feel like they're a family that would benefit from a visit, we try to look up when the next available appointment would be and encourage them to call. They need to call directly to schedule. We're not able to schedule the appointments for them. But if you're not already aware, we have clinics every day of the week in Brighton, Canton, the Briarwood Clinic, Northville, and West Ann Arbor. So 5 clinics right now running 5 separate days a week. And they do not need a referral. They can call directly to schedule that appointment. So if they need more hands-on help after they're discharged, the outpatient clinics are a good source of support. Aside from that, we have our lactation warm line. That's an 800 number that reaches us here in the hospital. So when they call the hotline, they choose their prompt for either the NICU population or the birth center population. And then we have a commitment of returning their call within 24 hours. It's not an emergency line. It's a general helpline for general lactation questions. So it's really important for any of you who will be working in triage. Please know that if someone calls in with mastitis symptoms, it's not appropriate to refer them to our lactation warm line. If they are calling in with actual mastitis symptoms, they need to come in and be seen by a provider. It is outside the scope of practice. Lactation consultants are not able to diagnose or to prescribe treatment for mastitis. We can educate on prevention techniques and management techniques going forward. But if they truly have symptoms of mastitis, they need to be seen by a provider. And if they're within their triage timeline, they should come into triage to be seen. So just know that the lactation warm line it's not appropriate to refer mastitis calls there, other than for general questions. These are just some general common questions we get from parents that we thought we'd put together to give you a recap of some of the answers. Most parents ask, how often should I feed my baby? And remember, we want them to be responsive to the hunger cues. So anytime the baby's showing hunger cues, they should offer the breast, or at least every 3 to 4 hours. Anywhere from every 1 to 4 hours can be a normal feeding frequency for a newborn. So if the baby's still sleeping at 3.5 hours, they should definitely wake that baby and try to feed the baby. How do I know if the baby's getting enough? Again, behavioral cues. Let's talk about the hunger cues of tight fists and coming to the mouth and rooting, and then the signs of contentment after a feeding. If that baby's still showing any activity or any searching for food after feeding at the breast, they probably didn't do a good job at the breast and they need some help. We can't have someone feeding endlessly, ineffectively all night long and the baby not getting what they need. If they've made a good effort and the baby is not satisfied, we should be talking about a possible supplement. When can we start using a pacifier? There's really no hard timeline on that. But again, we want to encourage them to pay attention to cues. So if the baby is showing cues to suck or bringing their hands to their mouth, you have to take that as a hunger cue or possibly a gas pain, but most likely a hunger cue. So if we respond to that hunger cue by giving a pacifier, the baby's not getting the food that they need, they're at risk for weight loss, and mom is at risk for a low milk supply. So for the first couple of weeks, while we expect a learning curve, we expect babies to have some difficulty, we expect a delay in the milk, we want that to be happening frequently at the breast. We don't want to be interfering with the pacifier because we want to get breastfeeding off to a good start. Once the milk is in and the baby's gaining weight and breastfeeding is happening very easily, the pacifier is no problem. So they can eventually introduce a pacifier once they feel confident with breastfeeding success. Does the baby need to eat on both sides? Not necessarily. If the baby feeds well from at least one side and reaches contentment, there's no need to feed from both sides. Again, watch the hunger cues. If the baby ate well enough on that first side, one can be good enough. The next feeding, the baby should move to the other side. Do I need to burp the baby? You should attempt to burp the baby when switching breasts after feeding or to address discomfort. So if the baby's showing signs that they're uncomfortable, yes, I would recommend burping the baby. Make sure parents understand the technique as well. When will my milk come in? Typically milk comes in between day 3 and 4. It can take up to 5 days postpartum. So if mom is all the way through the 5th day and she's not seeing an increase in her milk supply, she should reach out for further evaluation. Is there anything I can eat or supplements I can take to get my milk to come in sooner? Nope. Again, the evidence does not support any kind of supplement. There may be cultural beliefs about things to eat to increase milk supply, but we speak mainly in terms of supply and demand. So if the baby's not latching well or moving milk effectively, mom should be pumping to take care of her milk supply. Is there anything I should not eat? Again, cultural beliefs come into play here. There may be things that some cultures don't want to eat while they're breastfeeding, but there really are no recommended restrictions. As long as mom's eating a well-rounded, healthy diet, she should be fine. Keeping in mind that her body's going to make milk for her baby probably regardless of what she eats, but eating well will help her feel better. If I give some formula, will it affect my milk supply? Well, the more formula the baby takes, the less time the baby's at the breast. So if the baby's taking meals away from the breast, it's important to remind the mom to be using the breast pump so that she's getting adequate stimulation. These are some case scenarios. We'll take a break here and we'll come back and go through those in just a minute.